and welcome to the second Scottish Drugs Forum webinar to mark International Overdose Awareness Day, which takes place on 31st of August each year. If you missed last week's webinar on the impact of networks of people who use drugs and change in drug policy, you can find it along with all the previous COVID webinars on SDF's YouTube channel. Today we've also relaunched the Stop the Deaths initiative, which reminds us that overdose deaths are preventable and we all have a role to prevent them. This year's theme is the role of families, and specifically the role of families as lifesavers, and it's supported by Scottish families affected by alcohol and drugs. You can find out more about how to get involved with the initiative and the role of families at stopthedeaths.com. So usually every year we'd host an international conference for International Overdose Awareness Day, but obviously that's not possible this year. Instead, we have a slightly different format, given that we have presentations from colleagues in Canada and Australia who, unfortunately, due to the time zone, can't join us. The speakers all kindly agreed to pre-record a presentation specifically for this event, and I'll introduce them in a moment. After all the three presentations, we'll be joined by Colin Hutchin, the Chair of Scottish Families, and my SDF colleagues Jason Wallace and Austin Smith for a panel discussion and to answer any questions that you might have. And please do submit these questions throughout the presentations. We don't normally get through them all at the end just because of the time, so the quicker that you get them in, the more likely the chance is that we'll get round to answering them. If you're new to GoToWebinar, you'll see that the question tab, which is usually up on the top right hand side of your screen, has a questions button there, and if you just input your questions there, it's private and it's only seen by our communications team in the background. We won't identify you when we ask the questions, which might help people if they prefer to be anonymised. And we might run slightly over today just because of the videos, but we'll definitely finish by 2:15 to give us enough time for discussion at the end. Okay. So our first presentation is from our friend and colleague Garth Mullins from Vancouver, Canada. We were lucky to have Garth in Glasgow last year for our conference, and some of you might have also been present at our conference and heard him speak, which was absolutely awesome. Garth's the host of the Crackdown podcast, which I would strongly encourage you to listen to if you haven't already. He's an award-winning documentarian and long-time community organiser. And when Garth visited Glasgow, he also spent some time with the Glasgow City Centre Engagement Group, which is the network of people who use drugs discussed by Jason in last week's webinar, and provided a lot of inspiration for the members to develop that group. So we'll just go to his video now.
Hey everybody, my name is Garth Mullins. I'm talking to you from Vancouver, Canada in your recent past, because now it is International Overdose Awareness Day. So I'm addressing you virtually. I wish I could be there to do this in person because it's always better. I'm the host and executive producer of a podcast called Crackdown. I'm also a member of the Vancouver Area Network of Drug Users. And I'm a drug user activist. I've been a opioid user most of my adult life, heroin and methadone, but really there hasn't been an opioid that I haven't tried. So maybe a connoisseur as well. So thanks everybody for having me. I got about 10 minutes of comments, just particularly on the situation with overdoses here in Canada and the COVID-19 pandemic. And you know, we gather today on a day like this. It's not a very nice day. It's not possible to wish someone a happy International Overdose Awareness Day. The problem is the politicians in our country and yours maybe are not as aware of the cost of this as they should be. So I'm just gonna look at the email here and see. You guys gave me some questions. So how does COVID-19 affect people who use drugs? This has been complicated, right? Because we've been saying for years, don't use alone. That's one way that people can protect themselves. You know, drug users, lots of us have Narcan. Here you go. This is what they look like in Canada, Narcan kit. Very, very nice design. Not like your guys' ones. Hang on, I bet you I even have it. No, you guys don't want to see me go looking for it. Anyway, it's a little case. You know what they look like over there. And inside is you got your rigs, you got the actual Narcan, breathing mask, because we do put oxygen in, we do give people breaths, and gloves. So people have that and are encouraged to get trained and use it and keep it around. And so if drug users are using together and one of them overdoses, the other can bring them back. And we've done that an awful lot of times around here. But during COVID, we've had to say no. Maintain space. Don't be right next to other people. So it's quite a contradictory message for people to hear. And I think a lot of drug users have been felt stuck between those two spaces. The other thing that's happened is a lot of our harm reduction facilities, including safe injection sites, what you call drug consumption rooms, have diminished capacity. So for social distancing, so people can keep 2 meters apart, there's less capacity in them, so less people can get in. There's also been less hours sometimes and less staff sometimes. So less people are able to use their drugs in a way that is observed. I guess another one of the complications from COVID-19 is that the borders have been closed, and the illegal drug market here in North America, as most of the world, is very global. So there's supply chains that go all over the planet, just like most commodities now, and closing borders restricts the supply chain. So the price of stimulants, cocaine, and crystal meth has gone up. Some of these have gotten rarer, and what's sold as heroin, which is mostly fentanyl right now, has gotten even stronger. So we've noticed the coroner has found concentrations of even stronger forms of contaminated drugs in people's system. So the next question. The next question is, have I seen a rise during the pandemic overdose crisis in fatal overdoses or other drug-related deaths due to the public health crisis? Absolutely. Here in British Columbia, Canada, we have a population that's not that different from Scotland, and the last 3 months probably have been record months. So the highest ever number of monthly overdose fatalities that we've ever seen. So yes, more people are dying. It's a more dangerous time. There's more call-outs for non-fatal overdoses. So we're all still reversing overdoses as drug users and comrades of people who are in trouble, but also, the ambulance people are still running around too. You still hear sirens wailing. Like, if I get through this 10 minutes talking to you without a siren blazing past the window over there, I'll be surprised. But now that I've said that, maybe just Sod's Law, it will happen. I mean, that will be good. That'll be good. The next question is, have any positive changes been implemented? Yes, they have, and I'll tell you how that happened. So usually for methadone, you have to go every day to drink it at the chemist or the pharmacy. The first thing was the federal government changed the rules so you don't have to. More people can get carries, more people can take their methadone home, and you can visit your methadone doctor over the phone or over the computer. So it's just not putting people directly in these physical locations. Seems to be doing all right. That's one of the things we've been fighting for forever. We were in meetings with the federal government, and eventually this broke. So drug user activists definitely had a hand in this. As we saw the pandemic getting closer, we were telling the government the moves that they ought to make for this. In BC, I was a co-writer of a policy called Risk Mitigation in the Context of a Dual Public Health Emergency. And of course, that's a mouthful, but it was a very quickly written policy by which doctors are now able to prescribe hydromorphone, Dilaudid, benzos, Dexedrine, not exactly the perfect pharmaceutical version of what people are doing. So not the pharmaceutical version of heroin, crack, or speed, crystal meth, but cousins, things, family members of that same molecule that are more closely related than methadone. And I know a lot of people, in BC, a lot of doctors are like, what the hell? We're supposed to be using methadone to treat people and to kind of nudge them away from the drugs that they were doing before. But in BC, in Canada, the drugs are just getting stronger and stronger and stronger and stronger. Fentanyl, carfentanil replacing heroin And meanwhile, the methadone is getting weaker. So a new sort of branded formulation was introduced a few years ago that doesn't work for a lot of people. So the drugs are stronger, the methadone's weaker. You've got this big gap to fill, and a lot of people are falling through that gap all the way into their graves. So a lot of us in the drug user activist movement have said, look, it's very nice. People can get treatment, recovery, and everything, but that doesn't work if they're dead. So job number one, keep people alive. And to me, that means if people are wanting to use heroin, give them diacetylmorphine, give them pharmaceutical grade heroin. This has happened in Europe. We've tested it here. It's not rocket science. And we all in North America learned this painful lesson during alcohol prohibition. There's no need to learn it again. But I guess we learn from history that we don't learn from history. So yeah, that policy was a breakthrough. It was good. It was a good step forward. You know, it was sort of casted as temporary. We were going to fight for it to be permanent, but you know, I guess we'll see. I guess we'll see what happens. And like I said, the doctors who are really uncertain about this are resisting, are just saying no, I'm not going to prescribe this. So we're still having a big problem with doctors that are like this person is sick, this person has a problem, I'm going to go fix them, instead of like we as drug users saying, look, I just need to stop having to grind every day to get my fix. I need to stop having to do something that's from the dangerous illegal market that could kill me. Just let me level that. You know, that is a huge, massive step in someone's recovery. If they're not scoring off the street, if we're not having to come up with the money to do it, if we don't have all those interactions with law enforcement and the hospitals, you know, the courts, all that, it stabilizes your life a lot. You can do a lot more with it. And the fourth question is, what changes do people who use drugs want to see? So this is the same demand that I've really thought about for probably 20 years, is you know, prescription heroin. Like, the thing that people want to use has an equivalent that's at the chemist, that's at the pharmacy. It's just the rules that don't let us have this. And for us, for the overdose crisis, that's how we get out of it. You know, you just have to let people have the thing that they're doing anyway. And that's what we've been demanding for a very, very long time. That's what'll get us out. So, you know, I don't know how that translates to the experience in where you all are right now. I can tell you, though, the only way that things ever change is when we fight for them. So the number one ingredient, if people want a safe injection site, better naloxone distribution, better harm reduction supplies, or if they want to go the full thing for decriminalization, legalization, and a safe supply, which is what I want, you're going to need a drug user movement. You're going to need drug user activists like me, like all the people I work with, like the people that I met when I was in Glasgow, all working together with allies and fighting the government, understanding even when the government says very nice things, as long as they keep those laws in place that make us criminals, they're the enemy. And so on International Overdose Awareness Day, I say the people who look like big friendly figures in the world, like Justin Trudeau, well, he's an enemy to drug users. He is continuing a system that is causing our deaths in the thousands. And so International Overdose Awareness Day, who I want to be really aware is, I want the lawmakers to be aware. I want those people to know that they have blood on their hands unless and until they change the laws. And we're here to help them draft the new ones. So, yeah. The phone lines are open. They can call anytime. Anyway, thanks very much, and I hope we all see each other in person soon.
That was really great from Garth there, and I'm sure we'll have plenty to pick up on at the end. So I'm just going to move straight on to the next presentation. Up next is Jane Dicka from Melbourne, Australia. I was really lucky to meet Jane when I spent some time there on my travel fellowship. Jane manages the Drug Overdose Peer Education Project with Harm Reduction Victoria, which is a fantastic peer-led organisation that Jane will talk about in more detail in this presentation. Thank you.
Okay, hi everyone. First, I'd like to acknowledge the traditional owners of the land which I'm presenting this presentation from, which happens to be the Wurundjeri people. I'd like to pay my respects to their elders, past, present and emerging. And I also want to thank Kirsten and the Scottish Drug Forum for inviting me to speak. My name's Jane. I work for Harm Reduction Victoria, which is the Victorian Drug User Organisation. We're located in Melbourne, Australia. We're peer-based, which means everybody that works at Harm Reduction Victoria is either a current or ex-drug user, but most of us are current. You know, it works really well. Drug users listen to other drug users. We have a peak body called ABLE, which is located in Canberra, another part of the country. And we first received any funding in 1988 from our Department of Health and Human Services. I just want to give a bit of context. I'm not sure how much you guys know about this wonderful land called Australia. Sorry if you already do know it, but I can bring your attention to the bottom part of the screen here, just here. This is Melbourne. That's where all the cool people live. No, that's where I'm coming from. There's Sydney. They're the two main cities that most people have heard of, and an ongoing battle over which one's better. We've got the better coffee, they've got the better weather, I guess. But Sydney got Australia's first injecting room. That opened in 2001, and it remained in trial status for a long time, like I think more than 10 years. We got this country's second injecting room here in Melbourne in 2018 on a 2-year trial, but last year they announced a further 3 years of trial. So, and you know, recently they did an independent review of the injecting room, stating that Melbourne needed a second one to take the pressure off of the first one. So let's see if we get our second one. I'm not holding my breath. So can I tell you a bit about what we do here at HRVIC? We've got a program known as PAMS. I think it sounds like the name of a fine gentleman's establishment, but what it actually stands for is Pharmacotherapy, Advocacy, Mediation and Support. So it's a telephone-based service with the main aim of keeping people on a program. So the two types of pharmacotherapy that's available here in Victoria. It's methadone and Suboxone, which is a buprenorphine naloxone combination that comes in a strip that people put under their tongue. More recently, the monthly injectable versions of Suboxone, known as Buvidal and Sublocade, have been trialled, and as a result, some people are being maintained on that. OSTs dispensed from community pharmacies. It can be quite expensive, especially if you're unemployed, and PAMS gets a lot of calls asking for help with financial assistance. We're usually unable to do that. What we can do usually is pay just a few days and get them through till payday, and then the worker will negotiate with the pharmacist and the consumer to come to some sort of contractual repayment agreement. Yeah, so I'm sorry if I'm babbling. I hate Zoom. Have I said that yet? But yeah, by the way, we've got about 14,000 people on the program any given day here in Victoria. So dance-wise, probably one of the longest running programs that we have at Harm Reduction Victoria. It used to be called Rave Safe. They attend music events, the multi-day festivals. They've got over 200 volunteers. Like, they came from very humble beginnings, and they've built themselves into a really well-oiled machine with a really good reputation. They're really well known for training. They do training for security and event staff, as well as people who use drugs at events. They set up a chill space, and they will monitor people that don't perhaps need medical attention, but you know, they just need someone to monitor them, whether that's because they need a rest or, you know, they're having a psychedelic experience and just need someone to make sure that they don't hurt themselves. Yeah, they do a lot of what they call trip sitting. Yeah, and they've recently established DanceWise New South Wales, and they're looking at perhaps having DanceWise Queensland. So health promotion, this is a bulk of what we do at Harm Reduction Victoria. We do a lot of stuff around Hep C treatment. This on the screen is a series of posters that we developed when the new DAAs became available. And we just wanted to let people know how different the new treatment was from the old treatment. These posters were really popular, and I just think because they were simple, they were easy to understand. Yeah, they went down well. So the health promotion team does a lot of peer education workshops with people who use drugs. We do safer using education, which includes vein care and filtering. We also do workshops, of course, on Hep C and other bloodborne virus transmission risks, treatment options, safer ice use. We try and keep them really relevant and interesting. It can be hard sometimes. The PATH project, that stands for Peer Assisted Treatment for Hep. It was a pilot trial that employed 2 peers, both with lived experience of drug use and Hep C. We outposted them at a busy needle and syringe program in a primary healthcare service, and their main role was just simply to engage with people and build some rapport with the intention of eventually hooking that person up into some Hep C treatment. It was a new way of approaching it, and the workers did some great work. Okay, but then some pandemic happened and we had to suspend it. Okay, so the peer networker program here in Victoria, it's fully legal to go to a needle and syringe program and get equipment. However, if you were to pass that equipment on to someone else when you're not registered to do that, you can get into trouble. We know people come, they collect equipment for themselves and their mates. And so what we did, we sort of targeted people that we knew that were doing that. We approached them about joining the program. We spend a couple of days training them. They do all the peer education workshops we have on offer, as well as an introduction to needle and syringe program work. They get their first aid, and then we register them with the Department of Health and Human Services, so they get a legit legal outreach card that allows them to hand out equipment. We get them to keep some basic stats, and then each month we swap them their stats for a little amount of money. But it's really, really successful. It's you know, mainstream NSPs see mostly males around 30 to 40 years old, whereas peer networker program is seeing 55% females and a lot younger group of people that aren't showing up in NSP. So, you know, that's awesome that they're doing that. They also act as an unofficial warning system. Nothing works better than word of mouth. If there's a bad batch out there, you know, by the time the health department will get the information and make up a resource and get the okay to put it out, you know, quite often the bad gear's gone. Peer networker program, drop the word, it's out there straight away and everyone's onto it straight away. Yeah, it's a really good program. So communication, it's important for any role. Although the bulk of our communication is done face-to-face, we've also have our flagship publication called WAC. It's a magazine for users, by users. We've been producing WAC since we first came together. And for those of you who are interested, we've got every issue we've ever done available on our website. There's people out there who don't really even know who Harm Reduction Victoria is, but they sure as hell know what a WAC magazine is. You know, we're also active on social media, maybe not quite as active as we could be, but we are there. The DOPE project works at educating people who use drugs, preventing overdose, as well as recognising and responding to it. We've had take-home naloxone available here since 2013. And that's probably enough about me babbling on what an awesome organisation I work for and telling you how wonderful things are, because this happened. Yeah. You know, that nasty thing. Yeah, I thought it was all smooth sailing, but not quite. You know, I can remember it was the CEO had planned to take some leave and I'd been given the role of acting up. And he was about to go on leave when all this started to happen, and he was going to cancel it. I mean, he was going to go to Vietnam originally, but he couldn't travel. But, you know, I said to him, no, take your leave. You need a rest and I'll be fine. And little did I know what was to come. You know, everything changed. We couldn't do any of the stuff we normally do. We couldn't have events. We couldn't do workshops, nothing face-to-face, no outreach. And that's sort of what we did. And the thought of having to transfer it to all online was just so scary. We're getting there. I hate being on Zoom. Have I mentioned that yet? Maybe already a few times, but yeah. So in the following days, you know, our government advised people to stay at home where possible. People were to work from home. You know, we weren't the kind of service that was going to adapt to working from home easily. You know, was starting to get staff geared up into doing that, you know, starting to audit what equipment people had at home in order to be able to work from home. Yeah, it just, everything sort of started to get real. And I remember at first, when I first moved to working from home, I thought to myself, I think I might like this, you know. I'm not a real morning person. I enjoyed being able to sleep in a bit longer, but I think it was about day 4 I started to, get me out of here, I hate it. So yeah, you don't know what you got till it's gone, I guess. But March the 12th was when reality really started hitting me in the face hard. So the first major event to fall was our Australian Grand Prix. That was followed by the Comedy Festival cancellation, the International Flower and Garden Show. People started panicking as they started to close the borders. Illicit drug supply was threatened. Prices went up. More people trying to get onto pharmacotherapy, which was really hard to access, especially if you're wanting to start up. People saying, what if my pharmacy shuts down? Or so, you know, by April the 11th, they had brought out changes to the OST guidelines. I've never seen anything get sorted that quick before in my life, but they did. And it went from, you know, people went from having to get a script each month to only having to get one every 3, and some people every 6 months. It used to be a maximum of 4 takeaway doses with usually given 2 and 2, and all of a sudden people were able to access 14 takeaways at a time. They introduced telehealth for appointments, which doctors were happy to prescribe OST by telehealth unless it was someone they'd never met before. You know, they didn't like starting someone up on a program, which caused a bit of a hiccup because, yeah, people were scrambling to get on OST thinking that, you know, our illicit drug supply was going to run out and they were going to get forced into involuntary withdrawal. They also made it possible for third-party pickup. For people that were COVID positive that needed to be dosed, they could now nominate somebody else to go and get it for them. So, and that way COVID positive people didn't have to be out on the street and or going into a pharmacy. So yeah. But how do you run a community-based peer program in the middle of the pandemic? I don't know. I really don't. It's the $64,000 question that we're still looking for answers to. It was such a complete 180 from what I was used to. I was struggling just to be able to stay on top of things. The number of phone calls that we were getting from people concerned about what's going to happen, how are they meant to score if they have to stay at home. You know, it was kind of crazy. And for a short time, there was this really false rumour going around that the methadone was going to run out and the pharmacies weren't even going to be able to get it. And you can imagine what sort of panic stations that sent through people. But yeah. So, at Harm Reduction Victoria, we set about getting some resources out to our community. We developed these 3 here, 2 of them specifically around drug use and 1 dedicated to pharmacotherapy. And you know, the points we put on these resources were the repeated questions that we were getting from people ringing on the phone, yeah. So, you know, we had a lot of rough sleepers across the city and they were unable to go home and isolate because they didn't have a home to go home and isolate to. So our government said about housing Victoria's homeless people. There's about 2,000 people that they put up in the now empty hotels in the city. It was, the housing workers did an amazing job of getting these people off the street. Some people had been really, really long term homeless, you know, some people that hadn't slept in a bed for 10 years. It was really amazing. And, you know, what they'd do, they put them in a hotel, they'd pay for the first couple of weeks, and then it would get to, if they wanted to stay on, they needed to start contributing out of their benefit. And, you know, I started to wonder when this thing's over, what are they going to do? Push them all back on the street? But recently they announced that they've extended the funding until April next year. So, and by that time, they hope to not have to have anyone exit back onto the street. Hopefully they will have housing sorted for them after all. I don't know how they're going to do that. It's a pretty big thing to say you're going to do, but yeah. So it was pretty chaotic at the hotel. So like staff that were used to dealing with international travellers all of a sudden being faced with our cohort of people, our motley crew that we call them, they just had no idea how to communicate with our community, and they were actually scared. So we got in and did a lot of training to the hotel staff in how to deal with our community, which, you know, made things a lot better. I know I'm babbling, I'm sorry. Hang in there, I'm nearly finished. Okay, so don't know if you heard about this. I'm amazed at what some people on the other side of the world hear about Australia, but our government, for some reason, decided that they would announce immediate lockdown to 9 of the public housing towers, which had approximately 3,000 residents in them. It was a really punitive measure. It was really unfair the way it was done. People had no warning whatsoever. We started to get a few calls, as well as seeing social media posts from people within the towers needing to be dosed with OST. But it wasn't only OST that people needed. There was hundreds of people with normal scripts, heart medication, antibiotics, eye drops, you name it, that they needed to get filled. And yeah, we also had a doctor that was on the ground with us. You know, if anybody had gone into withdrawal, he was willing to give them the injection of Buvidal, you know, to help them through or whatever. People that were on a program already, we were able to continue to have them dosed inside. You know, but there were people there that it was such a strong police presence. They were so intimidating, and they refused to work with us for the first 3 days, and it made it really hard. And there were residents in there, people in there. I spoke to this one guy who didn't live there. He'd just gone there the night of the lockdown to score himself some pot. When he went to leave, the police were at the gate. Sorry, he can't go. He said, but I don't live here. They said, bad luck. You're caught in you go. He said, where am I supposed to sleep? And they said, well, whoever you were visiting, go back to their house. He couldn't say to the police, well, it was just a, you know, mangy pot dealer that I don't know that well. I can't ask him if I can crash there. So this poor chap was left wandering the halls for most of the days that they were on lockdown. But, you know, there were people in there that just wanted cigarettes, for example. There was alcohol and benzo withdrawal, which is really serious. That was going on. It was chaotic. It was really, really stressful, and it was hard. I was down there for most of the days of that lockdown. I was constantly doing cigarette runs, and people were just so grateful for, you know, what wasn't really a big thing on my effort. But, you know, I remember one day I'd gone to the base of the towers to meet someone and give them the cigarettes that I'd just got for them, and there was a policewoman standing there, and she said, oh, you know, these people, you know, they're just so ungrateful. What are you on about? She said, oh, that woman in there in the foyer, she's so belligerent. She wants coffee beans, marching up and down like she should get coffee beans. And I said, listen, you know, I like to have a coffee in the morning. That woman in there, she's done nothing wrong. She's not a prisoner. She's not a criminal. Well, she is a prisoner. You guys are locking her in there, but she's done nothing wrong. Why can't she have some coffee beans to have a cup of coffee in the morning? It's not that big a ask. I'm sure you had a coffee before you came to work. You know, and this policewoman, you know, just couldn't see any sort of reason. It was just really awful, you know. And there were people locked in their flats with animals. You know, I'm a huge dog lover, and, you know, you spend your life training the animal to let you know when it needs to go outside, and then all of a sudden you're having to tell your animal, no, not going inside. I mean, yeah, it was really, really poorly thought out, poorly planned, and yeah, I think there's a few class action lawsuits that are going to come in the future from that, I tell you. So yeah, I just have included some pictures from the actual event. You know, all the people prancing around in you know, PPE, and a lot of the residents didn't even actually speak English, and they just were no good at informing residents what was going on either. You know, they got all this food delivered to them, but nothing was halal. And there was a huge Muslim community living in these blocks, and just, yeah, I remember there was a case of a woman who had given birth to a premature baby. And, you know, she'd been going back to the hospital each day to visit her baby, but all of a sudden she couldn't even go back and visit her newborn child. And, you know, I could go on and on and on with horrible stories, but, you know, I won't. Yeah, this is just some of the windows that people took photos of, you know, like up here in the top, a whole family, you know, they're not very big apartments. You know, there was a lot of domestic violence going on, and yeah, they were very, very small flats, and I think it was a cruel and unusual thing to do to them. And it didn't seem to really get us out of the shit that much better either, but yeah. So that's me. I've come to the end of my presentation now. I feel really weird because I can't put it to you, the audience, for any questions, but if you have any, please don't hesitate to send me an email. I'm more than happy to explain something, or yeah, if I haven't been clear. But once again, thank you so much for putting up with me. Yeah, I will sign off now.
Okay, thanks for that. That was great from Jane. I was really impressed when I went over to see the work of Harm Reduction Victoria, and I'm sure you'll agree that they do some incredible work from there, from what you've heard from Jane, and I look forward to talking more about the content of our presentation at the end. And last but by no means least is Petra Schulz from Alberta, Canada. Petra is one of 3 founding directors of the organisation Mums Stop the Harm. And I first came across Petra when I saw a TED talk from her and heard about the work they do to advocate for changes to drug policy and promotion of harm reduction strategies. A really powerful group with powerful messages. And over to Petra's story now, please.
Hi, I'm Petra Schulz with Mums Stop the Harm, and I'll bring you greetings on International Overdose Awareness Day from Edmonton, Alberta, Canada. Mums Stop the Harm is an organization of Canadian families who've been affected by substance use. We started in 2016 with the 3 of us. There were 3 co-founders, Leslie McBain, who lives in British Columbia, and Lorna Thomas, who also lives in Alberta, and myself. And all 3 of us had lost sons to substance use related causes. My son Danny, I have Danny's photo here for you. I guess it's hard to see. So this is Danny's photo. You can also see a gallery of all of our loved ones on our website. Danny died in 2014. He was one of the early victims of fentanyl in Alberta. And before he died, I didn't know about fentanyl. Actually, I didn't know that much about substance use. The information we'd been giving as families was not to enable to let people hit rock bottom, to practice tough love and those kind of things. We never really practiced that, but we also didn't have the tools to do things right. One of my greatest regrets is that I did not learn about harm reduction until it was too late. I also did not know about the high risk of relapse and overdose during a relapse. All these things I learned after it was too late for Danny. After his death, I realized that from media reports that more people were dying, but yet there was nothing coming from health authorities. There was no action from government. And so I started to reach out to media and to health authorities. And one morning I was listening to the radio, and there was a story about a warning about E. coli tainted spinach, that people should not eat that spinach. And I thought, why do we care about people and spinach? And here we have so many people dying from a preventable cause, and nobody does anything about it. So I started sharing Danny's story in media, and that's how I connected with Leslie and Lorna. And for the first time, I felt I had somebody who understood what I was going through, because previously it seemed like people were either blaming me for being a bad mom, or us having been not a good family, and Danny for making bad choices. A lot of blame of bad choices. He had choices to make, and there are consequences for choices. When I met Leslie and Lorna, I found other women who understood how I felt, the grief, the despair, but also the guilt, the shame that comes with it, and how we felt we had to do something about that. And I also met women who wanted to make a change. So together we started out simply by registering a domain name and starting a Facebook page. Now we have close to 1,400 Canadian families that belong to us Canada-wide. Now, many people join us to engage in advocacy, but many more join us because they need support. In terms of our advocacy, early on we worked for things like making naloxone, the antidote to reverse an overdose, making naloxone available widely and without prescription. And we were successful, together with other advocates and health professionals, of course, and we were successful in making that happen. As a movement, we also worked towards getting a 911 Good Samaritan law, meaning that if you call 911 in an overdose, you will not be charged, or at least in theory, should not be charged with possession. So these were some of the early aims, but really the big targets we've been working towards is decriminalization of people who use substances, and towards provision of safer supply. In terms of decriminalization, most of us really feel that legal regulation is where we should be. And I usually don't say legalization, I say legal regulation, because substances should be regulated based on the harm they cause, which is not what's happening at the moment. A substance like alcohol is way too widely available. And cannabis in Canada, while legally regulated, the regulation leans more towards commercialization than making the substance available in a safe and affordable manner for people. So these are our big targets that we are working on right now, and this is especially important during COVID-19 because there have been so many more overdoses right now with the intersection of COVID-19 and the overdose crisis. We find that supply routes are disrupted. You probably have the same situation in Scotland, I imagine. Supply routes are disrupted, and we have substances just becoming way more tainted. The other thing is that people are using alone more. Some harm reduction services are shut down. Sometimes people are afraid to access them. People are told to stay at home, to socially isolate and such. So that has resulted in huge spikes of overdoses. And British Columbia, for example, has seen record numbers not seen before. And this is really heartbreaking to all of us in the movement, and those of us who try to keep our loved ones safe. As I said earlier, a lot of families join us for support. So the two areas in which Moms Stop the Harm work are advocacy, but also family support. In terms of family support, we have closed groups on social media for people who are grieving. Most of us in the organization have lost a loved one. Several families have lost more than one family member, and many families have lost a loved one and have other loved ones who are struggling with problematic use. So we have close support groups for grieving families. We also have our Healing Hearts grief support groups that normally meet in person. At the moment, some of them might meet in a park and such under COVID-19 conditions. Some have gone to Zoom meetings, and we are working on a project to start family support groups for families who have a loved one involved in problematic use, and we're trying to support that loved one and trying to support with a harm reduction approach and a positive approach that helps the person and helps the family. So these are projects we're working on at the moment. For International Overdose Awareness Day, our focus is on exactly raising awareness, reducing that stigma, One way of doing that, we have a series of banners. Normally we try to have events, small and large, in various communities. This year, the money that we had set aside for those events, we are using to buy banners, or rather billboards, in communities like Ottawa, our capital, in Victoria and British Columbia, Edmonton, Calgary, Alberta, in Montreal, in Quebec. So basically with the message, overdose can affect anyone, highlighting somebody's brother, somebody's sister, how a family is affected. Some of those we're using images from the International Overdose Awareness Day website, and for some we're using the images of our own loved ones, because we have found that the photos of our loved ones sends a powerful message. The photos and the stories of our loved ones is really our most powerful tool to open hearts, to ultimately open minds, and get people engaged and get them to think differently and consider those aims that we are working for, like decrim and legal regulation. We also have a campaign for International Overdose Awareness Day. It's called the Blue Ribbon Campaign, where the idea is really to paint the town purple. Purple, of course, being the color of International Overdose Awareness Day. We encourage people to tie ribbons on trees, on lampposts, anywhere in public, in front of their house, in their community, and to engage in that way and raise awareness. And what we have found that in some neighborhoods, for example, neighbors have offers to also put blue ribbons around their trees or lampposts. So again, it's a way to engage and reduce that stigma and create awareness. Our folks in Winnipeg got an ice cream shop to make International Overdose Awareness Day purple ice cream. We try hard to get buildings and important structures lit up in purple. In Edmonton, we have an iconic bridge called the High Level Bridge that will be lit in purple. In the CN Tower in Toronto, we will have displays on the Burrard Street Bridge in Vancouver. So it is probably the biggest day, and we get together not only to raise awareness, but also to support one another and to remember our loved ones, and to really, really show people that they matter and that they're important. And another way we show throughout the year a campaign we have is our memorial photos, where families gather in iconic locations in their city. We had one on a famous beach in Vancouver, on a hill above wineries in Kelowna and British Columbia, at Niagara Falls, at the Legislature of Regina in Saskatchewan, at an iconic bridge in Edmonton, which I took part on, and on an Indigenous land in southwestern Alberta on the Piikani Nation. We partnered with that nation to have a photo taken there, and people stand together with the photos of their loved ones, holding crosses or something that symbolizes their grief. Some of the Indigenous families that joined us held drums or blankets and such. And we reach out to the media with those photos and say, hey, these are the people that are affected. For one thing I'd like to talk about in terms of what makes us effective as an organization. As moms, we have that voice. We can share the stories of our children, but we could never go alone. So what we try really hard as Moms Stop the Harm, we take the lead from, for example, the Canadian Association of People Who Use Drugs, or other organization of people who use drugs, and what they do for their advocacy. And we do our best to amplify their voice and to share their stories and maybe put a different angle, different spin, but that we really work together with one voice. And many of us who are active in advocacy in our community, we work with others. We work with the people who use. We work with academics, we work with health professionals, with anybody who works in advocacy. And that's really what makes us strong, is this collaboration and the alliances with other organizations working towards the same aim. Other family organizations, but also people who use, and people in recovery, people in the wider harm reduction community. So if there is any message I would pass along to anybody, don't try to go to you alone. The strength is in numbers, but the strength is really also in our stories of our loved ones, and helping people understand that while an overdose can affect anyone, it is one of the most preventable deaths around, and people are dying not because of the tainted drugs. People are dying because of our bad drug policy. So we can change that policy. We can make the needed changes to move towards safer supply, towards legal regulation, and prevent future deaths that way. And that is just what our hope is, our aim, and what motivates us. Sometimes often we feel despair. We live with our own grief. I live with the grief for Danny. But then to see this preventable death occurring over and over really can lead to despair. But what's really important is to turn that despair around, turn it into energy, sometimes turn it into anger, but turn it into energy to work towards change. And I'm so pleased that I was able to speak to you today, and hope you have a wonderful International Overdose Awareness Day. Ours will start a little later when yours is already wrapping up. But we are united globally in this movement, and together we can make the changes. So do take care, and thanks for the opportunity to speak to you. Sending my love to you all. Thank you.
Okay, thanks very much to Petra from sharing all of that. It was really powerful. And I think one thing that's quite striking that Petra mentions there at the end is about seeing these preventable deaths happening over and over and over again. And what we've seen from this dual public health crisis is with COVID, that when a true public health emergency is declared, that actions can be taken very quickly. Law changes can be fast-tracked, and we would really like to see the same type of approach associated to preventing the deaths of people who use drugs. So I'd now like to invite Colin Hutchin, Chair of Scottish Families Affected by Alcohol and Drugs, to join us along with my SDF colleagues, Jason and Austin. If you could just join me. I've been very lonely here, so it's nice to have some company. And Colin, great. Okay, Colin, welcome. I wanted to come to you first just to allow you to introduce yourself and give us your thoughts on the presentations that you've just seen.
Okay, thanks, Kirsten. Thanks for inviting me along, first of all. I'm really glad that we're here and the voice of families is included in a webinar like this. And it was really interesting listening to the videos, all three. Really interesting, and I'm particularly interested in what Petra was talking about, of course, from a family perspective. But I think everybody can probably see how there's a huge overlap between what families are concerned about and what they hope to see in terms of changes and going forward to save lives. It's the same issues. I mean, they're talking about people who use. They're not talking about themselves now, really, because many of them they've lost their loved one. But even family members who are still living with someone who's got a problem with their consumption of substances. What they're doing is helping to keep them alive. And I mean, I think it was Garth that made a really good point about, recovery and services are great, but they're no good to you when you're dead. So it's really important that people continue to do what they can to keep people alive. And I think it was Petra that mentioned about how little information she had initially. And once she learned more about it, of course, it was too late because their son had died. And that's really, really sad. And how often that happens because families don't get access to enough information unless they know where to look for it and they feel inclined to. But people tend to try and hide away because the stigma related to problems with substances prevents them from getting help and seeking help for themselves. But she made that a really good point about, the only advice people get is often about you need to make sure you're not enabling. You've got to let them hit rock bottom and tough love is what is required. Well, that's a high-risk strategy, and what they've discovered, and we know here as well, that a lot of people can lose their lives because of that strategy in a way. So it's a high risk. It may work for some people, but I think what's more important is that people just still feel connected to families and friends, and they don't feel different and other than, that people still care for them, they love them, they can show them compassion, and they're much more likely to get well under these circumstances than the sort of, tough love, rock bottom type approach. So it's great, and it's so important, I think, for families in Scotland. Scottish Families does a great job in trying to support people throughout Scotland. We're lucky, I suppose, in a way. Scottish Families was set up about 13 years ago, I think it was, 17 years ago maybe now. And it was just a couple of mums, if you like, the start. That was a grassroots movement, but it's progressed quite a bit. And we've now got about 18 staff, and we do get funding from the Scottish Government, and we're getting a lot of other funding from elsewhere. So we're not just relying on donations. But it's important. Scotland has a significant problem, we all know that, but we're not alone. And just as we often say that to family members, that they mustn't feel like they're the only one, that they're alone with this, because they probably have been concealing it. They get a lot of benefit from talking to other people who had the same experiences, understand how they're feeling, how difficult it is. And I can see a parallel there with Scotland looking out across the world and realising we're not the only ones. There's problems everywhere. And we can share our experiences, how we're responding to them, and also learn from other people. And I think that's what the legislators need to do. They need to be prepared to be bold, learn from others, see what's happening elsewhere, and what is saving lives. That's what we want to do, and not shy away from making difficult decisions. So yeah, really, really interesting.
Thanks, Colin. No, there's definitely a load of points in there that I want to come back to, but I'm not going to take all the time. But what I did want to say was that thing about you need that tough love approach. I remember as a new nurse working in drug services, being at an appointment with a consultant who was seeing a person who was accessing our services but came with his mum, and he was heavily intoxicated, and the mum was at the point of despair with it, didn't know what to do. And the advice that she was given was that she basically needed to cut ties with him. And I just remember sitting there thinking, this can't be the advice that people are getting. There must be a different approach. So I really appreciate that that's such the wrong message to be given. So Austin, come to yourself.
Sorry, I make a tradition of doing that every Friday afternoon. If I can introduce myself, I'm Austin Smith. I'm the Policy Officer at Scottish Drugs Forum, and my job here is a simple one. It's just to read out the questions. And please keep the questions coming in. There's a few, but I'm sure people have lots to ask. But one of the questions it's an observation really, is just about two things, I suppose, just what you've said, Colin, about there being a commonality, the same problem, people facing the same challenges as individuals who are using drugs, have a drug problem, and the people that are involved in their lives and love them, their significant others. So that was one of the observations. But the question was, what's different in Scotland? So why is there less user activism, as Garth was exemplifying what's going on in Canada? And why is the family stuff feeling different? The groups are very local, and there's the National SFAD is an umbrella organisation, but the groups remain small and very local.
If it's okay, I'll come to Jason first about the networks, the people who use drugs, and maybe come to Colin after about the families related one. Jason?
Cool, thanks. So I'm Jason Wallace, Senior Development Officer with the SDF. I manage the peer research and volunteering, but wear many other hats, including I'm new a member of the Drug Death Task Force, Lived Experience, and also the City Centre Engagement Group. So the three of them were great, and There's so much to talk about, but I like the stuff that Garth was speaking about how they worked with the government to write policies straight away. And I think we heard that last week as well for Aaron, just about because people use drugs, it doesn't mean they're no educated and they don't have these skills. So it was really good to hear him talking about that. And he mentioned some really important stuff. He mentioned that giving people what they want, and that's pharmaceutical grade diamorphine. And we have a pilot running in Glasgow, but if we were able to sort of widen that right across Scotland, and he said that matter of factly, give people what they want to stabilise their life. That's exactly what people are looking for, something to stabilise their life. I mean, and for me, we've been doing a bit of work with the city centre engagement group, and when Garth visited, we invited him along, and he felt that was the beginnings of a drug user network. And when you look across the world, it's like some of these networks or groups that are established, it isn't rocket science. There just needs to be a resource and a will, and I think in Scotland now we've got the will, definitely. And Gareth spoke about it, having the allies, people that might have a history of using drugs but be in abstinence-based recovery or in recovery on a prescription medication. But what we don't have in Scotland is anybody willing to resource something like this, and that's a big sticking point. Thanks,
Jason. You and I must have the same brains, because I jotted down, I think, exactly the same points from Garth. Colin, over to yourself regarding the differences with family groups.
Yeah, I mean, I'm not sure just how different the family groups and how to support families is different, really, from what Petra was describing. It sounds quite similar in some respect. But yeah, there is a point about why is it so kind of sporadic, support, and that's a good point, and it's a challenge for Scottish families and other organisations all the time. Which, how do you reach people? You know, my wife and I, we were, you know, experiencing one of our family members having problems for a long time before we ever discovered a family support group. And when we did, that was in Edinburgh, one of the big cities, of course. It made a huge difference to us. It was a great weight off our shoulders. And consequently, we actually set up our own family support group in the town that we live in. And we ran that for 4 years. And we kind of hoped that that might be the start of an escalation of the numbers of support groups across the country. But it's difficult to get people to take that on without a lot of support, and Scottish families can support them, but you do need people to come forward and say, we need this here, and we need it all over the country. And we did reach quite a lot of people in these 4 years, but we're always aware that there's a lot of people that we're not reaching. And stigma, I think, is one of the big barriers to people coming forward to seek help, because they don't want to, you know, show to their neighbours or to friends or the rest of the family that they're going to a support group, because they're trying to hide this problem. And that's something that really has to be tackled. And I think there is a point as well that was mentioned about users not being represented. I think we still do have a problem with that in Scotland. There's been a big shift in terms of lived experience being involved in all sorts of ways, and particularly in the drug deaths task force, which I'm a member of as well. Lived experience has its voice there, and as does the families, thank goodness. But people who are still using, they've got a voice, and they've got a very pertinent and relevant view about how services might be developed and changed and so on. So we do seem to be still a bit hesitant about including users in any kind of consultation, but hopefully that will change.
And I think Jane talked about it quite differently in her presentation about lived experience, because the way that they describe lived experience over there is anyone who has experience of drug use. So that could be somebody who's still currently using, or somebody who had a previous history of drug use and is now abstinent. So they just use that word to encompass everyone who has experience of that. The other thing that I just wanted to ask, Colin, was the other side of what Petra talked about was about not just the family support, but they also do quite a lot of advocacy work for major drug policy change. So I wondered what your thoughts were on the role of families in Scotland supporting things like decriminalisation, drug consumption rooms, in the way that they seem to do over in Canada.
Yeah, I mean, I think that's some advocacy is something we talk about a lot, and how people, when they're not very well, are really not able to advocate for themselves. And sometimes family members are by their side and trying to advocate for them. But we're aware of quite a number of experiences in recent years where that hasn't been encouraged. It's a bit like what you were saying, Kirsten. The door sometimes gets closed on family members. No, you can't come in here because this is confidential. This is about us, the practitioner and client kind of thing. And I don't think that's right. If the individual is okay with someone else being there to help them and represent them, then why should that not happen? So, advocacy is a very significant issue, and Scottish Families does that on a kind of national scale, advocating for families generally and for policy changes which we think would help. And we're very happy to get involved with any of these kind of developments, working alongside organisations like yourself and others. And we've been doing that for some time now. And we're very pleased to be involved and to be included. But that wasn't always the case. Not so many years ago, families were not involved and included. So we've had to kind of fight for that as well.
Thanks, Colin. Jason, did you want to come in there?
I was just going to say, Petra made a lovely comment regarding that. She talked about what we actually do is we advocate and amplify the drug user's voice. We speak with one voice. I don't think we always see that in Scotland. I think we see people speaking for their own experience and advocating for their own needs, and we know families have a strong voice, but when that voice is closely aligned to the needs of the person still using drugs, it becomes a lot stronger.
Yeah, definitely.
The other thing that Petra talked about was about stigma and raising awareness, and that they've felt that really using images of their loved ones has been probably the most powerful thing for engaging with the media. And I know that 1 year for Overdose Awareness Day, we worked with the Family Addiction Support Service in Glasgow and created a video based on the stories of loved ones that had been lost. And every time we showed it, it was really emotive and it was really powerful. And do you think that that's something that we need to do more of in engaging the media, or what might be some of the issues with that side of things?
Well, yeah, I mean, it's like Petra was saying, of course, it makes it much more real for other people who see that every premature death through substances is a tragedy. We all see that, and we all know that, but it's a tragedy that affects a whole circle of people round about them. And if they're not able to talk about that, it's the stigma thing again. If they're not able to share that grief with other people, then they may never recover. They'll live the rest of their lives with this terrible pain. They'll always, have a sense of loss, but they can't be helped. And I think what Petra was saying is you can turn these experiences into something positive, and to use the energy, even if it's anger, to use that energy to fight for changes, to try and avoid these things happening in the future, because they can see why their loved ones died, and it's not in the way that the media often portray it. They know their circumstances were different, and nobody wants to end up in that situation. That's not what people set out to do, and it is about the safety of the substances they're using, It's about the legislation, the impact of legislation, criminalising people.
Yeah, absolutely. And that was one of the main things that Garth talked about and Petra came back to, was that lawmakers need to be aware that not changing drug policies that criminalise people who use drugs are killing people. And that was reiterated by Petra. Austin.
Yeah, the only other theme in the questions was about the role of stigma, the stigma for families, for people who use drugs, and for people who have got a drug problem, obviously, and what role that plays in the difference between, you know, what's happening in Australia and Canada and in Scotland.
Well, I think the stigma affects people wherever they live. I mean, a lot of what they're talking about, you know, the names are different, the places are different, but the experiences that they're describing are so familiar. And stigma plays a big part. And it's interesting as well that there's a kind of almost a hierarchy of stigma within substances. And it's ironic when you think just how widely used certain substances are, you know, whether it's cannabis, cocaine, or sometimes, you know, alcohol as well. They're all very commonly used. But certain other substances, opioids in particular, people don't want to kind of talk about that, and that's where families suffer a lot, because it's so difficult to share that experience and talk about what's going on or what's actually happened. And until that changes, then it will always kind of have an impact in terms of preventing people from getting support and learning. I mean, support is about people learning more about the problems that their loved one is suffering from. And when they get that knowledge, of course, it changes how they experience this as well and how they view it. And they will respond differently, and they'll respond in a much more helpful way to their loved one in terms of keeping them alive, but also probably helping them to get towards recovery and becoming well.
Jason, do you have anything you want to add to that?
No specifically on that, but I was wanting to just mention some of the stuff Jane was talking about, because this is discussions that have been happening in Scotland for a long time. So she opened in one of her first slides, talked about having a peer-based service, and it was peers for peers, by peers for peers, and we don't have nothing like that in Scotland. We have services delivered by third sector with peer involvement, but it was great to hear her also mention some of the simple things like having peer educators at needle exchanges, working in the PATHs project, supporting people into hepatitis C treatment. But one of the things that interested me was, for that peer group stuff, they were asking them to collect minimum data in each month, giving them a very small amount of money. And I would imagine the fact that they were getting that real-time data allowed the services and service providers to respond in a lot quicker, more timely effect than it does here, where we're 3 or 6 months behind the loop some of the time.
Sure. I think there's a lot we could learn from the work that Jane's doing over there and the projects that they've got running, for sure. Austin, we've got like 30 seconds left. Is there anything final that you want to add? I'm disappointed that we've gone through that so quickly. Austin, I was trying not to say it, but you're on mute.
In that case, I've run out of time to say anything, but thank you, Kirsten.
You used your time. Okay, so all that's left to say is, unfortunately, we are out of time. I want to say a huge thank you to Garth, Jane and Petra for taking the time to do those videos for us. Thanks to Colin for joining us as our guest panelist. I'm sure we'll have you back again. To my colleagues, including those in the background, Andy, Sophie and Andrew. And of course, Jason and Austin, who've joined today. And to everyone who's tuned into this webinar, thanks so much. The next webinar will be held next Friday, the 4th of September, 1 till 2. The webinar titled Sex, Drugs and Risk, Understanding Risk Behaviours and Harms for People Involved in Chemsex, Transactional Sex or Image and Performance Enhancing Drug Use, will coincide with the launch of a SDF research report covering this topic. A link to register for it will be included in the evaluation email that you'll receive, or you can visit sdf.org.uk/webinars. So thank you so much for joining us, and goodbye for now.